freeze-dried antivenoms are reconstituted using 10 ml sterile water for injection. The freeze-dried protein may be difficult to dissolve. Always read the insert in the package before application of ASV because we are not using it regularly. So today what I have learned because of presentation of this topic, tomorrow I will forget. But on literature in ASVs, it is specifically you can have some good idea what to do and what not to do. And what are the techniques? IV push injection. This is most acceptable because the doctor is by the bedside and can watch antivenom reaction, etc. Antivenom is given by slow IV injection.
Pure antivenom without mixing.
1 mile you take 5 minutes.
Pure antivenom would draw and directly inject.
No, tenable. I say no.
Oh.
I say it is tenable. It is only tenable. It is loaded. It is given with the vial supplied. Unfortunately, some companies are nowadays not supplying cartoons and literature is not there. It is particularly in our institution. I have checked all the vials here. In casualty, only one company is getting the cartoon and leaflet. I mean the package insert. IV push technique. Antivenom is given by slow IV, 2 ml per minute or rather slowly. This method has the advantage that the doctor, nurse, dispenser giving antivenom must remain with the patient during the time when some early reaction may develop and be worst. And now IV infusion, following that, reconstituted freeze-dried antivenom is diluted in approximately 5 to 10 ml of isotonic fluid per kg body weight. So it comes about 250 to 500 in our Indian scenario, body pressure. You can give it 5% next to the normal side, here is anything, and is infused at a constant rate over a period of about 1 hour. Local administration of antivenom at the site of the bite is not recommended. Although this route may seem rational, it should not be used as it is extremely painful, may increase intercompartmental pressure, has not been shown to be effective. This intercompartmental pressure and its mismanagement causes lots of amputations globally. Local administration of antivenom at the site of the bite is not recommended. Although this route may seem rational, I said it. I'm sorry. Antivenom must never be given by the IM route if it could be given IV. Antivenom should never be given in the gluteal region because very slow absorption, painful. Now coming to pyrogenic reactions, endotoxin reactions are common and usually develop 1 to 2 hours after treatment. Symptoms include shaking, chills, fever, vasodilation, and fall in BP. Verbal convulsions may be precipitated in children and caused by pyrogen contamination during the preparation of venom.
Now, how to calculate the total dose required for a patient?
Yeah,
Suppose.
Let serum reactions. It is developed in 7 days time. Clinical measures include fever, nausea, vomiting, diarrhea, itching, recurrent urticaria, arthralgia, myalgia, lymphadenopathy, articular swellings, mononeuritis, multiplex. At the earliest sign of a reaction, antivenom administration must be temporarily suspended. Temporarily. Epinephrine, adrenaline is effective. In pyrogenic reactions, cooled antipyretics, IV fluids for hypovolemia. Treatment of lead reactions, chlorpheniramine, adults 2 mg 6 hourly, children 0.25 mg per kg body weight in divided doses. In those who fail to respond, prednisolone 5 mg 6 hourly, children 0.7 mg per kg per day divided doses for 5 to 7 days. Observation of the response to antivenom. How do you observe how it is working? Nausea, headache, and generalized ache, it will give your answer. There is no specific dosage schedule for this ASV. You have to, the physician has to decide his own. Nausea, headache, and generalized aches, and we have got one chart in casualty that is very old, 115 bias. That is not there actually now. Who has given guidelines in December 2009. And there are so many associations in Southeast Asia. I will be coming to those points. But I have not stressed very much on doses because it is variable. Nausea, headache, and generalized aches and pains may disappear very quickly. Spontaneous systemic bleeding. But you have to keep one thing in mind, re-envenomation is there in snake bite. You have to watch after giving antivenom. You cannot discharge just giving antivenom, patient is okay, you discharge and he is coming again, dies in his house, after re-evaluation of the poisoning. That is from the soft tissue depot, etc., tissue fluid, etc. Again going to blood. Spontaneous systemic bleeding, it dissolves in 50 to 30 minutes. In shock patients, blood pressure may increase within the first 50 to 60 minutes. Arrhythmia, sinus bradycardia may also resolve in 30 minutes. Neurotoxic envenoming of the postsynaptic type may begin to improve as early as 30 minutes after antivenom, but usually takes several hours also. Envenoming with presynaptic toxins, carrots and sea snakes is unlikely to respond in this way. Ventilator, mechanical ventilators, anesthetic chapter is there for this presynaptic thing. Blood coagulability in 3 to 9 hours. Active hemolysis and rotolysis may cease within a few hours, and the urine returns to normal color. Recurrence of systemic envenoming. This is very important. Signs of systemic envenoming may recur in 24 to 48 hours. This is attributed to continuing absorption of venom from the depot at the site of the bite, a redistribution of venom from the tissues into the vascular space as the result of antivenom treatment. Criteria for giving more antivenom. Persistent or recurrent blood coagulability after 6 hours. Deteriorating neurotoxic or cardiovascular signs after 1 to 2 hours. In patients who continue to bleed briskly, the dose of antivenom should be repeated within 1 to 2 hours. You have given 5 vials, again giving one after 1 hour 5 vials. In case of deteriorating neurotoxicity, cardiovascular signs, initial dose of antivenom should be repeated after 1 to 2 hours, and full supportive treatment must be considered. I will take a little more time, sir, because the subject, otherwise I cannot make everybody understand these things. Conservative treatment when no antivenom is available. In villages, in our health units also, we had time when we didn't have ASP. When antivenom is not available, bite by species against whose venom there is no available specific antivenom. Assisted ventilation has proved very effective. Anticholinesterase should always be tried. Strict bed rest to avoid even mild trauma. Transmission of clotting factors and platelets, ideally FFP with platelet concentrate. If not available, fresh blood, this is not encouraged because it will further, this hemolysis process will be going on if you add fresh blood again. Intravascular injection should be avoided. Shock, myocardial damage, hypovolemia should be corrected with colloid crystalloids. These are all when we don't get ASP. Colloid crystalloids, albumin also will be given. Hypertension, pressure drugs, dopamine, epinephrine, adrenaline combination. Hypertension associated with bradycardia should be treated with atropine. Renal failure, conservative treatment for dialysis. Myoglobinuria, hemoglobinuria, correct hypovolemia and acidosis, and consider a single infusion of mannitol. Severe local envenoming, local necrosis, intercompartmental syndromes, and even thrombosis of major vessels is more likely in patients who cannot be treated with antivenom. Prophylactic broad-spectrum antimicrobial treatment is justified in these cases, otherwise routinely antibiotic is not required. You can try cephalosporin and other antibiotics. Surgical intervention may be needed, but the risk of surgery in a patient with consumption coagulopathy, thrombocytopenia, and enhanced pneumolysis must be balanced against the life-threatening complications of local envenoming. Neurotoxic envenoming. Antivenom treatment alone cannot be relied upon to save the life of a patient with bulbar and respiratory paralysis. Death may result from aspiration, airway obstruction, respiratory failure. A clear airway must be maintained. Cupped endotracheal tube should be inserted. Tracheostomy may be needed. Now, persistent renal